I'm Dr. Derek Lee, and I'm with Andrea Lebel, who's a physiotherapist. Andrea is very, very respected and established in her field. Uh, with all transparency, my son actually sees Andrea for his scoliosis as well. So I've been very impressed with her. As you can see, Andrea is, which I was it was interesting to find out, was the first physiotherapist in Canada to be certified with Schroth, and the first clinic in Canada to be have a full Schroth program as well. Andrea is also a board member of SOSORT, and has multiple certifications with BSPTS as a certified instructor, and with C's in terms of certified at a second level, and fully certified with Schroth. Andrea, it's all yours.
Thank you. Thank you for your invitation. I'm very pleased to present, and I hope I can educate whoever might be signing up to see this video. And I think the goal is to have education and to be able to make educated consent for whatever treatment you might choose in the future. So I'm in Ottawa, and as you mentioned, I do operate a small clinic which is focuses on scoliosis and spinal disorders. And we also have a scoliosis resource center, where anybody could come in, and it's open during weekdays, and we do free screening for that. I'm trying to advance my slide. Let me figure it out here. Good. Okay. So I want to point out a couple of other things. During this presentation, I used my course slides, which is the Do No Harm course slides, which I teach to all practitioners who prescribe exercises for the general public, and to make sure they know how to screen scoliosis, how to recognize scoliosis, or any other spinal conditions. Most of the presentations, or most of the topics we touched today, you have recorded version on scoliosis and spine online learning. That's a platform which is again open to the public, and for very minor fees, you will be able to access presentations, presenters, recorded webinars from experts around the world. And the funds which we collect through these webinars and speakers presentations, we support a couple of organizations, the National Scoliosis Foundation in the States, and I co-founded the Kenya Scoliosis Foundation. So these are the places where we are continuing education, as well as sending funds to help to reach patients and professionals. And the Do No Harm and the SSOL, the Scoliosis and Spinal Learning, is a proud sponsor of the eSOSORT, which is on June 20th at 10 a.m. EST. And this year is all online, so you're welcome to join and take part for watching presenters and all the presentations, which will be recorded and available for a whole year for you if you sign up. So I think Scoliosis Awareness Walk, we won't have it this year. This will be the 9th year. And we had families come from all across Ontario, some from even Quebec, to join us for this walk. And we are supporting the local hospitals to get equipment like EOS and some surgical monitoring equipment with the funds we raised there. So we won't have that walk this year. We all know why. And you can sponsor and donate directly to the hospital. So I want to point out, since it was one of the questions, where to go for evidence-based good information when you're researching and trying to choose the treatment options from treatment options out there. I used to say, when you type in to Google scoliosis, you have 8 million links come up, but now actually I checked, it is 14 million. So if you wanted to go through those links, it's going to take you over 100 years. So it's important that you go to the most evidence-based platforms, which may not be what you want to read, but it is something which you can be sure that many experts standing behind those platforms and giving you information, up-to-date information on scoliosis. So Scoliosis Research Society is mostly a surgical view society. They have non-surgical section as well. So it's important to know that many research has been funded by SRS and published. So it is something you can be trusting when you're looking at information on the SRS, srs.org. Under that is SOSORT, where I'm a board member and secretary for a while now. And it is an international organization, close to 40 countries, presenting each year at the annual meeting. We have courses before the meetings, and this year it's going to be online. And doctors, physicians, orthotists, chiropractors, psychologists, physiotherapists are members here. Patients could be members as well. So you're all welcome to join these conferences and take part in the courses. There's an open door policy here, so everybody is welcome. And this is any presentations or any publications go through SOSORT. It is going through a committee, and it's assessed and checked for good quality information and good quality research. So it is another area where you can search for information. As the Scoliosis and Spine online journal is open access. Now we are in a process of joining another journal, but you can get many old publications from that website. We're also in a transition of a website, so it's going to be any day now, sosor.org. Okay. The last international organization is the Research Society of Spinal Disorders. This is where all the researchers get together every 2 years and present their very high quality, amazing research. We had a combined conference with IRSSD, and we hope we have another one, SOSORT IRSD in a couple of years. And the last one was in Canada, in Banff, and we were amazed of how much we learned in a short period of time. And then you can look for surgeons. You can look for surgeons with open mind. I just put in one surgeon here, Dr. Michael Vitali, who was one of the first ones, with Dr. Boachi, who was the SRS president back in 2009, who were open-minded, and they were also interested in offering non-operative treatment methods. And this is something which is new. It's not very common that you see when you see a surgeon, they will offer other methods but surgery, which is completely right. They are surgeons, so they are more aware of all the information what the surgery can do. So, and you can see many surgeons who do not believe any of the non-operative treatment methods. And this is a presentation I gave at the Hospital of Special Surgery in a top orthopedic department in the United States. All the individuals in this room are spine surgeons and residents. You name it, the biggest names are sitting there. And after this presentation, there was not much of a consensus that this patient got better, from 52 Cobb degrees to down to 16. And the surgeons saying that it is not, doesn't matter what you have done here, this patient will progress and will need surgery. So you're just wasting the time of the patient. So this presentation actually available also on SSOL, and I'm going to present it on June 14th, a 12-year follow-up of non-surgical management of a case. And it has been a very popular case. I've been presenting it all around the world. And now HSS also, after this presentation, actually created a non-operative department and offering Schroth physiotherapy and bracing. So this was back in 2012, so it's a long time ago. Things have changed since then. And then I'm doing not just local courses at University of Carleton University on the left side, but also international courses to teach professionals and physiotherapists, whether it's a do no harm course or the certification course for treating physiotherapists. We have annual presentations from the clinic presenting our research at the SOSORT conference and some other platforms. And the resource center picture, and up there you can see a picture of the walk, which is not happening this year. So just a little bit more where all this information coming from, and what should we do when the child is diagnosed with scoliosis. And there are a lot of questions, millions of questions come to mind right after diagnosis. The families are searching for information. The teens are also asking many, many questions of themselves, of anyone they meet. And it is a really wide territory of known and unknown, and depends on whom you talk to and whom you see. And the teenagers, they want to know if they can dance, or they can do yoga, or they can do weightlifting, or what can they do in a gym. They are concerned about if they're gonna progress, if they're gonna get better, how do they sleep, how do they sit, how do they walk. They are really thinking about, worrying about every movement they may take if the curve will get worse by doing something. And what can they do and what they should not do. So we're going to touch on that a little bit. And if I need surgery, or when do I have the surgery, now or later? These are all big, big questions, and the family needs to make an educated decision for their loved ones. So it's not so easy to get that answer. And before I give you answers for all that, it's important that we take a look at what is actually happening with the scoliosis condition. What is it? What is the definition? And why it is important for us to actually know all the three-dimensional aspect of the scoliosis. So this definition is very well explains the structural component of the series of vertebral segments in extension, in lordosis, which after that deflect, which is lateral, and axially rotate towards the same side. So once you have a spine in your hand, or you're looking at your own spine, your spine during that scoliosis deformity is moving out of the natural curvatures in extension and lateral deviation and rotation in the same side. So when you're talking three-dimensional, it is quite complex. And when you're talking multifactor causes, it's also quite complex. So I'm just going to try to move my speaker here. Good. So what should we do? Should we get the patients or individuals more flexible, or should we increase the flexibility, or should we decrease the flexibility? That's also a huge question. Should we start doing yoga, Pilates, exercises, anything you might Google or take your, you find, there will be a lot. Yoga for scoliosis, Pilates for scoliosis, any type of exercises for scoliosis. So what should we do? What should we keep in mind? These are very flexible people. And I have a permission to show the yoga teacher on the top, who was actually doing a yoga pose, but I want to show you that his thorax, his rib cage actually could not rotate, not because he has scoliosis, it's just a structural individual limitation. And you can see what it does with the spine to achieve that yoga pose. And then you're going to see the ballet dancer here on the right side, which is a beautiful movement. And I don't think she has scoliosis, but you can definitely see what the spine is doing during this movement. So if she would have scoliosis going to the right in the thoracic area, this movement probably going to increase that Cobb angle curvature. And then down here, another yoga pose, nothing against yoga. It could be done safely. And we just had a yoga presentation on SSOL, which was amazing. So a lot to learn on poses and exercises. And this is a leg up on the side. And if this person would have a left lumbar curvature, it would be keeping more force to that curvature to progress. So it will be very important to take apart some of the movements, some of the activities you might choose. And then you can see a whole lot out there on the internet, 4 magical exercises for scoliosis, which clearly does not, whoever prescribed these exercises never read the definition of scoliosis. When a scoliosis, the first word they say is extension. Adding more extension, more backwards bending, it's clearly going to not stop the scoliosis, but giving a little bit more chance perhaps to progress it. So any of these movements, if you know the definition of the scoliosis in terms of extension and lateral and rotational component of the same side, you will see that extension exercise is passive, active. It's not necessarily going to make the natural curvature easier to regain. Also weightlifting on the right corner here, creating more rotational forces, and it is not necessarily the magical exercises. Nevertheless, this little boy who's struggling there to lift arms up and hanging off, I'm not sure how is he doing it, maybe standing, it is full of compensatory movements. So very important to look at what we give as an exercise and how they are performing the exercises. So these are no-nos. These are not something we would recommend for patients, and you can find these exercises everywhere on the internet. So don't trust them because you know the definition of scoliosis. These are physiotherapists who are giving exercises, and these are regularly trained physiotherapists. So they don't actually learn what's the right and wrong in the physiotherapy school. They learn that scoliosis is one plane of deformity, a lateral curvature of the spine, and they are thinking of that one plane of deformity. But if you know the definition of scoliosis, you know already that this person is not going to get better with these type of exercises. It will create compensatory curve, as you can see it on the lower back curving the other way, and the pelvis is pushed even further out of midline. So University of Alberta made a lot of local research. So since we have local research, Canadian research available, I feel that the professional community is listening a little bit more. So how to correct the position and the posture. This is a high level of soccer player with a double major curve of 50 of each. That means the thoracic and the lumbar both 50 degrees. And I'm asking everybody when they come in, show me your training move, show me your yoga move, show me what you have to do for your training activities. So she's a soccer goalie and showing me her side plank exercise. Clearly not what we want to see. And a trainer with the t-shirt on, with the tank top, whatever they wear, they don't notice that maybe, but it's not corrected. Then I say, well, show me the other side, how you would do it on the other side. And again, clearly is not a very stable pelvis, a very stable trunk. You can see the twisting and turning to perform the exercise with this double major curve is not so easy. So I will have to adjust that. I have to create a position where the pelvis, the shoulders are leveled. She has a little bit of support with an elastic band to maintain that and to not to harm herself during the training of the soccer practice, but actually maintain some kind of stability of the spine and the pelvis. This is not necessarily a Schroth exercise or any kind of exercise. It's made up on the spot. As we see, it's a combination of many things, but it is something which is helping this client to do so. Same with the planks. Many physiotherapists are giving planks for core and other trainers as well, and core and planks, well, it will be good if it's done well. But we already know about the natural curvatures of the spine. When we're looking at it from the side, we have a natural kyphotic, a lordotic area. We cannot lose that. We cannot lose the lumbar lordosis. That would be worse for the future. We really need to maintain the lumbar lordosis. So I'm not asking her to stop her activities, but I'm trying to help her to do it better. So you can see a little bit of here the lumbar prominence because of the lumbar curvature, and you might see a little bit of more prominence of the thoracic right shoulder blade because of the upper thoracic curvature, but she is in a better sagittal lateral view of the alignment. So very important to not just pick an exercise because it says it's for scoliosis, but you have to do it well for yourself. And you can see all of these exercises are very individualized. So because you already know the definition of scoliosis, you know that we do not want to flatten the upper part of the spine where we have a curvature, let's say to the right. Closing the shoulder blades, pushing the spine forward into more extension. So it is something often given to strengthen the muscles between the shoulder blades, and it is not necessarily any effort for the scoliotic patients because that's not the way the muscle is going to be exercised. It's really no-brainer for them and no effort to close their shoulder blades because it just already slides together. There's no rib cage or no limitations for the muscles to just kind of close on that forward position spine. Why is it forward position, that spine? So we know what's happening when the scoliosis develops. We know that the vertebra and the disc is growing a little bit faster on the anterior aspect of the vertebra, of the bone. It is a growth failure, it's a growth problem as the children are growing. There is always a lot of research now out why is it happening, how it is happening. We know it's happening. What starts it up is still a big question because this is going to be the million-dollar question to answer and take that idiopathic out of the diagnosis. So that will be, we find a cause. So a lot of things are happening in the nervous system. A lot of things are happening during growth, hormonal changes, and a fast growth period where there's a mixed information and some physical forces creating a larger growth of the frontal or the ventral part of the vertebra and limiting the growth in the posterior aspect of the vertebra. So there's some compression and some tensions. So it is important to know that if it is severe like this, the spine moves forward. So again, exercises which are doing more and more extensions will not help the scoliotic patients. And it is one of the, how should I put it, the most common mistakes I see to strengthen the spine, to strengthen the back, to get more mobility. Everybody goes into giving extension and strengthening exercises. So we can also see this during the screening process. When they are doing the Adams forward bending test, you can see an uneven arc from the lateral view. And you can already know that even though this child was only having a 30-degree curvature with this flattened and forward positioned segments of the spine, multiple vertebrae moving forward and going to move lateral and torsioning, this is going to end up to be a big curve unless it's very aggressively treated. So she already had the spinal fusion. We already knew that if she's not 100% compliant with bracing and scoliosis-specific physiotherapy, which in fact she did beautifully, this both together will have a little chance to stop this curve. But if it is not 23 hours of very good quality bracing and not a very motivated individual with compliance at home, we have other options, non-fusion and fusion surgeries. So it's not always the goal of the family to avoid surgery. I think we have to be flexible, and if it is causing more mental health issues and more fights at home, there is an option. There is a treatment option which is evidence-based to halt the curve progression, to stop the curve, is the spinal fusion, or now the non-fusion surgeries. So it's important to know that this is what you can observe on a severe scoliosis before a very fast progression. As soon as this child is growing, it wasn't in a brace as it was prescribed, the progression hit 50 degrees, I think, in a few months. So it is something which is visible. So how do we check during Adam's forward bending test the patients? If you have a scoliotic posture, which you might even after surgery or before or anyways without any scoliosis you could have. This is my son on the left side, and he was checked every day. He was screened on a daily basis, before breakfast, after breakfast. So you could see his posture is quite scoliotic. And as he forward bending, you cannot see any elevation on either side. So this is a non-structural, functional, postural scoliosis, you name it any way you like it. This patient, like him, I taught him how to breathe into correctively opening the rib cage evenly. He does it anytime I ask him or anytime he wants to. He works out in a corrected posture, not in this posture, and he does not have scoliosis. So it is a fast growth, a fast asymmetric soft tissue development, whatever you want to name it, creating a scoliotic posture. And also he prefers, he's left-handed, he prefers to use his left side, he prefers to breathe into the left side. So it is something which we leave it like that, let's say, and never be consciously explain to him what's happening. We're leaving it like that for 10, 20 years, it could become structural. So it is not an adolescent idiopathic aggressive curvature, but by positioning, by the forces of gravity and other vector forces, it could eventually create an asymmetric wear and tear and become a scoliosis in the future. But for now, he's completely straight. So what do you see in a structural scoliosis? During the Adams forward bending test, you would see a curve. You could see a curvature of the spinal processes. You can run your finger through it. It could be very mild, could be almost unnoticeable. And you also see some prominences. On the thoracic spine, you see the rib prominence of the rib cage. And on the lumbar spine, you see the lumbar prominence of the vertebral rotation and the muscles which are sitting on the top of it, creating a bump. So these prominences are very visible during the Adams forward bending test. So for that reason, you can imagine if we're giving bending exercises for scoliotic patients, bending exercises, it will be aggravating or increasing these rotational forces. So according to international guidelines, we will screen patients, and over 5 degrees is considered positive, but we are very careful of ordering x-rays. If you're really sure and the scoliometer is showing 7 degrees, that's probably the right time to order x-rays. That being said, there are large curves with less rotation and there's small curve with large rotation. So the rotational measurement not always represents the curvature inside. If the kids look scoliotic, if the posture is scoliotic and the scoliometer only measures 5 degrees, you probably still have to order an x-ray, and this kid maybe already have a 20-25 degree curve which needs to be treated if it is still a growing child. So ordering X-ray has to be very carefully done, because if, let's say, you order an X-ray for a 5-degree, not much rotated, not that scoliotic, and you only see 11-degree of scoliosis, the next X-ray you shouldn't be ordering next month. You have to order it in 6 months. Now, during that 6 months and a fast growth combination, you can get 40, 50-degree progression. It's very fast if somebody growing fast. So it's important to pick the X-ray timing the right time when you have some good baseline. And if the child is in fact in a very fast growth, you might have to have one in 3 or 4 months. And if you have an EOS machine in your city, then ask them that, you see this is fast progressing, get an earlier X-ray. So not to miss, fast progression could be 5 degrees a month. I've seen it even 10 degrees. So it's very important to catch the curve at the right time, not too early and not too late, when you are actually needing some treatment, okay? Scoliometer, you can use phone apps and anything else you might want to use for that. There's a water bottle method as well, so a lot of ways to screen out scoliosis. It is important to start the early detection and early diagnosis, not too early. We don't treat 10-degree curvatures, but it's still called scoliosis. But early means early enough that we can make a difference. So the treatment options, bracing part-time, bracing full-time, scoliosis-specific exercises. There are many methods you can choose from. And always the goal of the early treatment is, and any treatment really, is prevention of curve progression. We have to halt the curve. If the curve is not stopped, the treatment doesn't work. So we have to always pick the right treatment to be able to halt the curve progression. And we know the risk factors. It is very well known that the earlier the child is diagnosed, the risk factor of progression is much higher. More girls progress than boys just because they may be growing a little bit earlier. There's some more research done on hormonal and other aspects as well. The curve magnitude, usually 25 degrees and up, has a better chance of progressing. Growth potential, if somebody is really 4 feet, but all the parents are 6 feet tall, it might be a lot of growth left over. So the growth potential is also very important to try to figure it out. And we look at the Riser sign or Sanders sign with hand X-ray now to see when the growth happening and when the growth is finishing. Progression happens during the rapid growth spurts. So there's some months, there's some almost years here and there when the kids don't grow. That's not the time to be worried about progression. When you see the feet grow, when you see the pants are getting short, that's fast progression. You're gonna have to worry about then the progression of the scoliosis. Now, we measure height. We measure the height even down to the millimeters. And we encourage everybody to measure the height even down to the millimeters at the same time of the day, let's say every Saturday at 10 a.m., and see what happens. Now, you could have the child not growing, but you see progression. That means the growing happens in the curve and a major progression happens. So it's not 100% indicator, but at least if you know, I've seen kids every 2 weeks when they come, a centimeter of growth, that's a whole lot. So if you see any kind of increase in the height, even if it's 5 millimeter, you could be, I should put it, alerted and checking closely what's happening with the children. Curve progression happens between age 11 and 15, boys and girls, and it happens fast as you see it. This is a very famous slide from the International Association with the Duval-Beaupre research based information. So these are the ages when you are really alerted and watching like a hawk these scoliotic kids, because they will progress if they are not treated properly. So it's important. A few lucky ones percentage-wise, but if you reach 38 degrees by age 11, unlikely that this curve is going to stop and stay there unless you treat it very aggressively. Sometimes here. Okay. Curve progressions. We have many objective charts you can plug in the Cobb angle. These are, this is an older one in 1982 based on consensus of many famous spine surgeons. And you can, just as an example, 30 degrees, age 10, you go into that age category, 90% of progression. That means out of 10 kids, 9 will get worse. There will be one lucky one. If the curve, of course, higher than 60, they all progress. So it's important that you know the risk of progression. And we don't call low risk 40%. We try to call low risk like 25%. But again, if you have a child who has, let's say, 15-degree Cobb angle, which is a small curve just diagnosed, and it's 11 years old, every 4 children, 4th child will progress with that kind of Cobb angle. But if that person is already 14, only 1 out of 10 will progress. And if that person is 16, almost nobody will progress. So it is important that you look at it. It's not you know, it's not exact for everybody, but it's a major, many numbers are collected to create these charts. And we need to make sure that we diagnose the children early. When we get an early diagnosis, when we have early treatment, we're talking 25 degree or 20 degree, we can make a difference. I had many cases who are straight now, and it is not because you know, scoliosis specific physiotherapy magic. Is just because they were either compliant, or they had a German mother or a Russian father. And they had no choice of doing the exercises. But on the other hand, it is evidence-based. Dr. Negrini's team already produced evidence that small curves with a good prescribed scoliosis-specific physiotherapy and compliance could be reduced. Now a little bit about bracing. You had a question about bracing, what kind of braces we use. We really want to be able to have the brace create a curve correction, ideally 3D. So there are many braces around, and no matter how you call them, the brace could be a good brace or not so good brace. So just because the orthotists are trained in different bracing, you need the 3D view and the 3D knowledge to create a really good brace for that child, because the same brace may not work for the next child. So this is a brace concept developed by Dr. Rigo, what we're using at the clinic, based on a 3D correction according to the Dubuisset concept. Dubuisset was a very famous surgeon and very, I should be highly valued of his work in the scoliosis field. Not just the scoliosis, but the transversal plane deformity we have to incorporate in the brace, and inspired in a brace concept development by Rigo-Cheneau. Dr. Cheneau was the first orthopedic professional surgeon who developed a brace which is creating a 3-dimensional option in there. And that was in 1979, so it's not that long ago. So Dr. Rigo developed this concept further and created the 3D brace concept by Dr. Rigo. And Jelovic, she's a Serbian doctor who also works with Dr. Rigo. Also is, you can name it the new 3D brace generation. So we have many 3D braces available out there, but it is really depending on the good assessment, the good hand, and a good vision of the orthotist to create that perfect brace for the child. So Dr. Rigo makes the braces by hand. It's like an artwork. When he was in New York at Hospital of Special Surgery, took 2 days to file the brace carefully, to add the push pads carefully, and running through every orthotist there how to make the brace perfect for a child with a high risk of progression. And then they had the fitting and looking at how Dr. Rigo is adjusting the brace. The brace is not painful. The brace is not, how should I put it, limiting. The brace is not limiting this child to do the somersault or do anything she wants. It is keeping stable the spine in the best possible 3D correction until she grows, to change a little bit of the growth changes. Great growth modulation, let's say. So PSSE, what is it? Physiotherapy scoliosis specific exercises. This is how we call it in the international platform, and what it is and what is not. Since you know already the definition of scoliosis and you've seen already an Adams forward bending test, this is from the internet. I don't know who put it. I'm sorry. They cut it off, hopefully. And this says Schroth method for scoliosis. Now you already know when a child bending forward and we're checking the Adams forward bending test, this is where the thorax and the rib cage is the most rotated. There's no way a Schroth physiotherapist ever who is trained well will give a forward bending type of exercise like that. So just because it's called Schroth or just because it's called, doesn't matter how it's called really, you really have to check where that knowledge came from. And again, this is what we teach at the BSPTS school in accordance to Dubuset concepts. Scoliosis correction looks for the best possible sagittal, which is very critical these days, the sagittal and frontal plane alignment throughout combined distortional forces, not producing any, not even bad, but any compensatory or imbalance or disharmony. So when we are doing a forward bending, just this little picture here, yes, you're increasing the thoracic kyphosis. That may be good, let's say, because we know it's an extension deformity, but it also losing the lumbar lordosis and the cervical lordosis, that one movement. It will not just, how should I put it, maybe have a little percentage help there, but there's a lot of high percentage of harm there. So it's important that we do not create any compensation, any imbalance, any disharmony during the specific exercises. If you're interested in further knowing about PSSEs, the most commonly used and researched methods around the world, myself and my daughter co-authored the Hagit Berdishevsky's paper here about the 7 schools which are providing evidence-based scoliosis-specific physiotherapy. It's an open access, and you can look at that publication and read it. It's full of pictures, very nice publication. It's close to over 100,000 reads now on different platforms, so very popular publication. And it is also presented by the author on SSOL with a very long webinar. The recorded webinar is available, and you can hear the explanation of different schools, and you can see videos and so on. What it is really, methods from France, from Germany, from Italy, from Spain, from Poland, 2 different methods, and from UK. These methods all work. It's not something we have to compare. Do they work? Do they not work? They all work because they all have 3 things in common. active self-elongation, active three-dimensional correction of the body, and exercising in these corrective movements, adding breathing and balance and so on. They work in different ways. They work under different philosophies. It depends on what you, how should I put it, choose. You go with that method basically. And it is, you can see some different movements here. Some of the methods allow overcorrections and some compensations. Some methods like the BSPTS, zero compensations, maybe slight overcorrection in certain type of curves. So every method has their own philosophy, their own way of working with the patient. So I am aware of all the methods, and I am certified in a few. I met Crystal and Schroth in 2008, I believe, and we were pen pals, and we discussed cases, and I miss her a lot. But I first took my course in the Asclepios Katerina Schroth Clinic in Bad Zobenheim, when I first was exposed to the Schroth method in detail, and watched the large institute where every given time there's 200 patients in there doing exercises 4 to 6 hours a day in groups, some individuals as well, but mostly groups. How did this method come about, and how did it hit North America? I actually know. So first time, the big deal was the yellow book, which probably somewhere here, but I can probably have a slide later on, was published in English. I believe in 2007 or somewhere there. So the Schroth method book by Crystal Leonard Schroth was written by a physiotherapist and published in English. So it hit North America, and many who actually read the book were not sure what to do, because it's a very detailed book, and it's a very deep book. And if you don't have hands-on and you don't have somebody teaching you, I had many physiotherapists coming as patients, and they read it 3 times and they have no clue what to do. So it's important that you actually understand the concept before you read the book, and then it's easier for you. So once that book was published, one of the national conferences, I believe in 2009, when Dr. Boachi, who was the head surgeon there at Hospital Special Surgery, came to the SOSORT meeting, and with another physiotherapist in California, we had the book, and we were shaking like that, but we gave it to him, and he actually read on a plain back and gave it to Hagit Berdyshevsky, the physiotherapist who authored the previous article. And she went to study the Schroth method in Germany, and after that brought more and more attention to North America, and many, many courses have been taught by her, as well as her colleagues and other 4 teachers in the United States. So now it's very well known in North America what the Schroth method is, but you also know that there are many schools spin off the Schroth method. So there's not all Schroth is the Schroth. But how did it really start? First, it was called orthopedic breathing. Katerina Schroth herself had scoliosis, and one day she discovered if she's starting to breathe into the concavity, she's looking better and she's feeling more balanced. And based on that concept, many patients coming to her in Bad Zobenheim to start learning the exercises because they wanted to get better. Spinal surgery wasn't available those days, so bracing was very rare. And so these are always been very severe curves she has been treating in their backyard here and giving the patients exercises. I put this little boy down here because I had a patient with the case study, which was the 53 degree. looking very similarly. And this was also a very popular photo when this little boy who had not really an idiopathic scoliosis, more a polio type, was really switched his posture to within very short period of time to a corrective posture. So you can see that the Schroth method is really working on the corrective postures. You also see the breathing, asymmetry.
He must even imagine the one-sided activity of the diaphragm in his indented section of the trunk, and then exercise and feel this side to lift it up.
So this is the breathing asymmetry based on many components, the diaphragm being tighter on a concave side and more stretched on a convex side, the rotational component of the rib cage when the ribs are more open on a convex side, and it's just pure physics. Air will go with the path of the least resistance. There are already open ribs there. There's no effort to breathe there, and the concave side is getting more and more closed, the intercostal space and the diaphragm, because it's not used as much. So the orthopedic breathing, I was demonstrating that this was the base of the Schroth method, this very specific rotational breathing technique. And how it came about that one day Katarina went out to her backyard and found a half deflated ball. This is not her, apparently. I don't know actually, but this is not her. And she said, what would happen if we blow air into this half deflated ball? It looks exactly like my back. Let's blow some air into that ball. So she started to blow air into that restricted left concave side. And you can see on this patient, who was one of the patients, we believe, at the clinic, very severe scoliosis, very severe asymmetries of the rib cage, as well as looks like the left lung hardly ever functioned. And with this very specific breathing technique and soft tissue work, you're able to decollapse the concave side. So this was the base of the Schroth method. We also see when we are doing the posture assessment of our children here, that the rotational component of the rib cage is really visible, especially the larger curves. There's always a rib hump backwards. That doesn't mean the spine is there. The spine is still forward. Just the ribs are rounding backwards and creating this open space for the air to go there 10 to 20,000 times a day, every time you inhale. Now you can imagine, I mean, you've seen waterfront washing, the waves creating holes in rocks and all that through nature. You can imagine what 10 to 20,000 times of pressure could create a rotational force, and it's very difficult to change that. During the Schroth physiotherapy, we try to change that breathing function and try to open the concavity and somewhat not restrict, but creating a tension and a convexity to create the internal pressure balance, so the breathing would be a little bit more symmetrical. So it's just a little visual, very simple way we start teaching the patient some breathing, as well as just for you to see what the diaphragm looks like inside and how the doming and the muscle fibers might alter the bottom ribs as it's attached and the spine. We do the same work with the scoliotic patients who are fused and who are not fused. And it is important for, since you asked some questions about the surgery, that we are creating that stability, not just through the unfused segments, but also in the rib cage. The increased mobilization of the rib cage to open up the rib cage is still an issue afterwards. many patients actually come post-operatively when they're not really pleased with the appearance because the rib rotation did not take place. They still breathe the same way. They still doing the same rotational breathing into the convexities. So it's important that we retrain the breathing patterns and improve the lung capacity on the concave side and improve the rib expansion and change the balance and all the different things for post-surgical. So VBT and Apifix patients, it's the same thing really. We always work on a scoliotic posture, always try to avoid compensation, and always try to create a very symmetrical thorax with less rotation. I did see probably about 3 or 4 patients, maybe 4, maybe a little bit more, because I do see some of them who come from New Jersey as well, pre and post. Mm-hmm. They're pretty strong on doing pre and post. So, I just had one from Spain last week. So it's important that some surgeons actually not referring patients post-surgically to scoliosis-specific physiotherapy, which hasn't really been a routine before. So we have a little different approach. If they come pre-VBT and we know they are going for the VBT or Apifix surgery, we will actually work on the mobility and more flexibility of the curve as much as we can to make the surgery a little bit easier. It doesn't alter any of our exercises other than we might add a couple of them which we wouldn't add otherwise. So the breathing function, the breathing education, the posture education is the same, whether you have pre or post-surgical or non-surgical patients. The pulmonary function, we always check, and we always want to make sure that the patient's sagittal alignment during any activities during the day, sitting, standing, walking, sleeping, is correct. And we are basing that, if we have the sagittal x-ray, on the pelvic measurements, which are very, very personalized. It's just like everybody's fingerprint. So we have to make sure that we know how much lordosis, how much kyphosis this patient might need. See that. So again, I just took the Dr. Rigo's information here because it's the most comprehensive I know. And the treatment plan is really not as simple as giving an exercise sheet and go home and practice, or just give 2 exercises and do it. You know, just like, let's say if I have a knee problem and I can just do my leg raises, and whether it's 80% correct or 50% correct, the leg will get stronger. But here, when you have a 3-dimensional deformity, we really have to work with many centers. So the treatment plan of not just the cognitive, but the sensory motor and a kinesthetic training. It's a huge training for each patient. It takes many hours. And to treat the patient and to help to halt or improve his or her scoliosis in 3-dimensional posture and the thorax and the shape, that's what we do. And this is an assumption that if we improve the scoliotic posture, that will promote less curve progression or halt the curve, and according to the vicious cycle model, which we'll see in the next couple of slides by the vicious cycle. So this is very complex training. It is often I have a phone call and say, well, I can book an assessment, and can you already teach me all the exercises on the same day? Am I going to leave with those exercises? And can you give me just fax me the exercise sheet and things like that? Well, There's also a saying, when a physiotherapist finished 5 o'clock the work, the physiotherapist goes home, and another 5 hours, the brain is going and going and going, how to best approach that patient and create the treatment plan. Because by then, you know that patient is wiggling, the patient attention span is low or high. You know that they have done rhythmical gymnastics or never moved, just read a book all the time. So you have a lot of information of the individual, and you have to alter the treatment plan for that individual to be successful. It's not so easy, and it's not so simple. Sometimes you overwhelm a patient and they run away. Sometimes you don't give them enough and they say, well, that's not doing anything for me. So if you know, as you know, I always start, we call it warm-up exercises. We don't even call it Schroth, until I get to know the patients, until they get the idea what I'm trying to teach them eventually. And if they stick around for the warm-up exercises, then later on they'll know more. If they want to run, they run in the first 3 sessions, because it gets complicated. So we teach them, and it's not so easy to get not just learning, but integrating and living with the 3-dimensional postural self-correction. And then we learn how to do expansion of the collapsed areas, as I showed you before with the rib cage collapsed. And then we learn muscle activation, not losing the 3-dimensional achieved postures. So this is where we really have to be very stable. We can't move, because if we lose that the 3-dimensional correction postures, we have either not made any difference or we having compensations. So we have to make sure it's very stable. So this is why it is so weird that we are kind of putting people in some position, expect them to work as hard until they sweat, and you don't even see anything moving. So that's the goal. It's very hard. It's just like plank. I think the world record is 4 hours of plank or something like that. And even that is sinking down, because I watched at the end. there's movement there. But if you want to hold a plank for a minute without any movement, it cannot be easy. It's the same idea, just in another position. We have to hold and contract every muscle we can. And then number 4 is very tricky. We either have very talented people who just come, and the second visit they say, oh, I have to be honest with you, I didn't do any of your exercises, but guess what? I do it when I walk, and when I sit, when I sleep, I do it all the time. I said, great, you're at number 4. You don't have to do exercises. You just keep doing what you're doing, because you're actually doing exercise 24/7. So when the exercise starts, really, when you learn what you have to do. So once you have this integration into everyday life and everyday activity, you don't need to go and do your exercises per se. You have the muscle activation and you're using them. So you are already integrated into everyday activity and using them. So you are not going to be the one who will progress, we assume, and I see it, who can do this. Who can do this, they are really, really doing well. Then I have the patients, I have a very, very good, I think she also made it in one of my poster presentations, very good improvement just by scoliosis-specific physiotherapy, very compliant, doing it every day, beautifully doing the exercises, everything is perfect. And after 4 years, we still don't have integration. She gets up from the mat, she goes back into the scoliotic posture. Even though she improved 12 degrees, she still doesn't know how to integrate it into everyday activities. So that integration sometimes is a talent or some brain function, some brain activity of memory, muscle memory, motor sensory skills, cognitive, I have no idea, or all above. But it is the most important part. And it is not impossible to get improvement without number 4 on X-ray. It's not impossible to avoid surgery with number 4, but living with scoliosis for the rest of your life, you need that. Okay?
Mm-hmm.
So that's the critical part. So we are reshaping the torso. This is a 1-year Schroth physiotherapy and bracing for a 56 Cobb degree individual. You can see that she entered into the program with not so fit. We like it. We like it when they come not so fit because they don't have to work against their own muscles so much. And she reshaped her torso. You can see the concavity opened. You can see the whole shape of the child is beautiful. And she decreased it, I believe, 10 degrees. She's 46 maybe right now. She already discharged 2 years ago. She's stable for 2 years stable. She's living with this posture and a 46-degree curve. She did not want to have surgery. She wanted to try this first while she was actually on a waiting list. We had those days 2 years waiting list. So by the time they called her, they said, actually, you're not in the category to have a surgery anymore. So even if you want one at 46, you actually don't get one. So she's very happy, very active now. She's in university. We removed the brace, I believe, after close to 2 years, even quite early, because when I took the brace off, she was already standing like that. So she integrated. She couldn't go back into her old posture. So she was very compliant too. And we do the same after surgery. This is fusion. This patient was fused on the left side on a selective thoracic fusion. Actually, she was referred by the surgeon because the lumbar curve was increasing. I think she's also a poster, maybe it's on a website somewhere. And the lumbar curve was increasing after fusion to the level of possibly having a revision and extending the fusion. And before that, the surgeon said, well, you go ahead and try. And I said, that's great. You know, you gave me 2 referrals over the last 5 years, and they both were the most challenging patients. I can see that you really want to test my skills. But nevertheless, we did it. And the lumbar curve decreased 10 degrees. I think it was in the 40 range, but that was the side effect that she also looked posturally more balanced and more, the patient was very happy with this posture. So it is something which we do work post-surgically of the rib cage balance and the breathing function, as well as the symmetrical muscle activation to make sure that the spine and an unfused segments are more stable, not more mobile, but more stable and ready for the adult life. So you can see the concavity collapsing on the left side here with the fusion. So that is quite a straight spine in there, but the thorax was not altered during the surgery. And you can also see the pelvis shifted just like before surgery to the left here. So that means that there's a larger curvature here still coupled with the pelvis pulling her to the left. And when she's, this is just, I believe after a summer camp, we did photos, and after she did the summer program, she has a relaxed posture here. She could even breathe more into the left concave parts where you can see the ribs, and you can see a more balanced pelvis. So it's not an issue, and I have now probably about 5 or 6 patients post-VBT who's also working on posture. They're all girls, actually, because they are really not expected to look scoliotic after surgery. They're quite surprised they were not completely losing the scoliotic posture. So they're working on it, and not a problem. They're actually doing really well. So they're motivated by making those changes. So when do we see patients? We definitely see patients before and after surgery. We see patients during the called observation period, when they're not ready for bracing, and they are having maybe 20 or 23 or not exactly 25-degree curvatures, and they are called back in 6 months and they put on a wait and see method. They are observing them if they get worse. So many parents don't want to just sit and do nothing. So they start scoliosis-specific physiotherapy, and this is where we have those posters and x-rays showing straight spines, because they go back 6 months later and they automatically ordered an x-ray, even if I could tell don't need done, but they order an x-ray, so we have proof that they actually straighten their spine during the scoliosis-specific physiotherapy. And I think I have a case series in, I think it was in Lyon, I believe, when that was presented on 3 cases who have the same waiting 6 months and getting better and getting straight spines. And you had another case earlier today you saw. And then when bracing or surgery refused, many kids don't want to wear brace, so they can still try the scoliosis-specific physiotherapy. As I mentioned earlier, the girl who was non-compliant with bracing but did the 2-hour physiotherapy, for some reason she also decreased 12 degrees. It's not something we guarantee, but it could happen. Every scoliosis has a postural component and a structural component. So the scoliosis-specific physiotherapy could improve the postural component, and then you left with the structural component. So usually what I see 10, 15 degrees could be postural components. So let's say you have a 50-degree curvature, let's make it more of a surgical, a 60-degree curvature, and then you saying, okay, this is clearly surgery, but you have a postural component of 15 degrees, and then once you finish with scoliosis-specific physiotherapy, you have a 45-degree curvature, which is your structural curvature, and maybe that's what you have to live with, but it is below the standard of fusion criteria. So often happens with the compliance. And then there are families who just never want to have surgery, whether the child has 60 or 80 or 90-degree curvatures, they don't want to do surgery, so they are doing the physiotherapy with us. When they're braced, we always recommend physiotherapy, and now Columbia University coming up with the standard of bracing care, and it is part of that. You have to have prescribed bracing, then you have to add scoliosis-specific physiotherapy. And just a little bit of Katarina and Crystal and Schroth's drawing here, original drawings, which I have a permission to use for presentations from Krista. You can see all the torsions and all the muscle imbalances, all the muscle length and strength changes which happens during scoliosis. So we have to normalize these muscles lengthwise and strengthwise to create a muscle brace during the scoliosis-specific physiotherapy based on the Schroth method. So this is the vicious circle. Ian Stokes, very famous spine surgeon and researcher, and he first presented the vicious circle model to understand more, to see what's happening in scoliosis. And we have this triggering event, which we kind of not know, that's why we call it idiopathic still. And then slowly there's asymmetric loading, torso deformity, and progression. And it feeds into it, and it is getting worse, and that's really the progression. With many, many components, there are lots of references on the bottom if you're interested. So when physiotherapists start to intervene, or the orthotist try to intervene, or the surgeon wants to intervene into this vicious circle to stop it, we have different phases we can make a difference. So if it is right after asymmetric event and loading, we can change the loading, we can change the muscle imbalance, it could possibly stop or slow down this vicious circle. Clearly, when surgeons intervene with fusion or BBT, again, they are changing the loading, changing the and halting the progression. So it is something which we all want to kind of take part and intervene. So how does this scoliosis-specific physiotherapy exercise look like with all the components together? This is a gymnast who's doing gymnastics in this posture 15 hours a day. Sorry, week. That's too much. A week. So she's training, and she's a strong athlete. She understands her body. And she has about a 35-degree curvature here. She comes with this posture. Clearly, she has a right curve, lower thoracic curve, pulling her to the right, and the pelvis is compensating, pulling her to the left. Her head position is a little bit altered, and the shoulders as well. She also, you can see that she's a very flat back, very collapsed, very extended, according to our definition of scoliosis. And when we do the physiotherapy in this pattern, only with this type of pattern, we can do a tiny bit of overcorrection. So she is not exactly midline with her exercise. She's going a little bit over to the left side. You can see those left ribs popping out and back from the concave side, opening them up with the breathing, stabilizing the shoulder blades. You can see muscles working. Her shoulder may be a little too high. We need a little bit more elongation, but this is her first session. So she was one of the fast learners, athletes. Sometimes they just soak it in. She was also one of them who said, well, I'm doing it all the time. Mom said she's not doing any exercise. I said, don't worry, she's doing it all the time. And she reduced her curve for the next x-ray for 8 degrees. I'm not saying it is a miracle or anything like that. She actually got it. What does all that on the right side mean? She did her axial elongation. She's not collapsed into her flat back anymore. She did her sagittal normalization. She's created a little bit of kyphosis, little bit of lordosis of her spine. She definitely pushed her right curve a little bit to the left. She derotated with the rotational breathing technique, and she stabilized it. She's staying there, and then she's going to get her muscle activation. So she did all that in the one exercise. So this is one exercise. I was able to a little bit overcorrect the pelvis, a little bit overcorrect the trunk, and making sure that her hip and shoulders are able to manage the movement. She had actually tight hips, so that's why the leg is out there. And then this is a slide from the German Schroth Institute to show you the goals. Definitely the goal is reduction of the progression, always, 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 that's the goal. And then we have the cardiopulmonary function. We need to improve that. We know that even a 30-degree curvature, they're noticing lower function in the lungs. It's not affecting the quality of life, but it is a fact. And then improving quality of life, making sure that they are pain-free, and improving their mobility of the extremities, really, and mobility into the correction to gain postural stability. Often the surgery might be postponed or avoided. These are more information about, how we plan for the treatment and how we do the group exercises, let's say, in our clinic. And everybody is doing the individual corrections. These are small curves which are responding well for Schroth physiotherapy, and the braces we use. You can see all kinds of braces here. As long as they give you 30 to 50%, some of them, in brace correction, and they look good posturally on the frontal and the sagittal plane, they are good braces. So depending on where they get the brace, we have here braces from Spain, from Toronto, from the States. That one was, I think, also Toronto. So we have many braces here. Somebody even came with a spine core brace, mild curve. So we have no problem as long as they can maintain their postural correction with the brace the same way as we have it without the brace. And yes, the smaller kids who are treated longer and we are changing the growth, this is a growth modulation, the bracing really, as well as VBT, as well as anything else we try to do during growth, we can make a difference. This is one of that case which present for, started in 2008 and now it's 2020. So we will have an 11-year follow-up of this child. And again, progression risk, we already talked about it, but many, many different ways of checking the risk of progression based on the Cobb angle, based on bone maturity. So once the risk is high, we must treat. We have this little chart, what we do with patients, especially because maybe I'm going way over time here. Sorry, too many slides. Cut that.
I love it.
I don't know how to stop. Anyways, so this is something which is in Canada, it's very important to know that education is lacking, detection is lacking, pre-basing period is very few because when the kids are actually diagnosed, every third one is already in the red circle. So it is something which is which we're working on and educating the public. And also the patients, we're educating them on the vicious cycle, vicious circle for the postural corrections of ADL, what they have to do to change their learning posture, let's say when they do their homework, to intervene in the vicious cycle at the asymmetric loading and to create less opportunity for the curve to progress just because of the vector forces of gravity and compression in the spine. We spend a lot of time on education of how to sit, how to stand, especially if they are not braced. If they're braced, they are braced, gonna do that for them. So we definitely learn more or spend more time with the unbraced individuals to make sure that they learn how to sit correctly, how not to do their favorite activities. And we explain that, you know, that posture does not cause the scoliosis, but if you are going on your right side there and going asymmetrically, spending 3-4 hours on the computer like that, that curve is not going to be less for sure. And we teach them standing postures. This is not feeling straight. This is looking straight. So we're going to have mirrors to prove that for the patients, how to stand in the corrected posture, how to feel that it's corrected, because it's sure not feeling straight for them for a very long time. How to sleep. Depending on their curve pattern. Again, if they're braced, is not an issue, but if they're not braced or just selective fusion or just selective VBT, it is important that we protect the lumbar area. So we have to make sure that the sleeping position is not affecting or not increasing the curve progression. Again, just a little bit more explanation of the sleeping position. You can see this right thoracic curvature, sleeping on the right side, how the rotation increased and how the curvature is visible, while when she's on the left side, she is actually opening up the concavities just by pulling her shoulder up, and she's a little bit more balanced. Now, everybody's sleeping position will be different. Regular exercises, what do they do? And it's not just me saying it, it's a very well respected, I think Order of Canada was given to Dr. McGill, kinesiology background, who authored many books about back pain and saying that many exercises, however often prescribed, are not evidence-based. So he's advising some of the exercises are really not doing what they're supposed to do. So you have to really check the exercises, what you're given and what you're not supposed to do. So this is Krista's poster of what not recommended, what we really don't encourage patients to do, and we change these for them. And we explain every single one by one what's wrong with them. I mean, you know already from the definition of scoliosis, extension is not the answer. You know the rotational component of the scoliosis, so rotation is not the answer. If you have two curves, one of them will collapse with side bending, so that's not the answer. And going upside down, losing, sagittal profiles, it's a really loading curve may not be the answer. So I put in a hyperkyphotic situation, which is also could be changed as we diagnose it early. It is also a big problem for teenagers, the Sherman condition or the pre-Sherman condition, when they are either having sway back or increased hyperkyphosis. And it is maybe postural, but could be also structural. And the remodeling the lumbar lordosis on any patients is very critical. This patient actually was horrified that he will not make it into the military, everybody in the military in the family. And he had a kyphotic lumbar region. You can see that it's not structural. He was able to change that, and we prescribed exercise in this position, and he did them, and he's in the military. So he's very happy, and it is a remodeling. We measure these parameters, we create personalized exercises in a sagittal profile as well to make sure that the patients are improving and not losing their sagittal profiles. Staying active is very important. Physical activity and having fun is good for you. It's not always going to be in a perfect position, but if you're doing 1 hour of physical activity of any kind, it's not harmful. It's a healthy thing to do. If you're able to do it with some alterations of your postural corrections towards the postural corrections, great. But if you're just having fun, improving your lung capacity, doing some physical activity of any kind, we don't stop patients from doing physical activity. This is a video, but I won't play it. It is also important where you spend many hours doing some of your favorite activities, like doing playing cello here with the right thoracic curve, how to control that during playing your instrument. So I guess it's playing. Doesn't stop. Doing yoga or any other exercises, you're gonna have to again think about what is this exercise doing for us? How can we change it? How can we level up the pelvis? How can we maintain the spine in a better position? How can we not add compensations or progressions? Running. Are we gonna run with lumbar kyphosis, or are we gonna run with more stable pelvis with the lumbar lordosis? So all those things are very important. I'm done. Not yet. Okay, so many presentations are available on Scoliosis and Spine Online Learning. If anybody wants to go deeper into yoga, deeper into learning more about scoliosis, it's there. It could be rented. It's very inexpensive. I already showed you, we're supporting lots of other organizations to make sure that they can learn in a very low fee. So when you pay something for $30, then someone else can watch it for free in another country when they can afford it. So it's important that you join if you want to. Scoliosis and Spine Online Learning. It's not a charity. It's a new organization which I co-founded with my friend Hagit Berdyshevsky. So it's a US and Canadian-based online learning. We're reaching out right now 59 countries. If you know anyone in the number 60, tell them I want 60 countries by tomorrow. But 59 countries is pretty impressive. And then you can sign up for ESO-Sort, as I mentioned, this June 20th. We also have a free webinar just before ESO-Sort for scoliosis support on SSOL, so you're welcome to join us. And if you know any physiotherapists whom you want to learn all this and more, you can give them my email address. Right now, we canceled all courses until October, but we hopefully gonna add another level 1 course. Now we have 3 levels, more or less 4 levels of this education. It just changed, but local physiotherapists will get the certification in about 2.5 to 3 years, full certification to do this method. Done. Thank you so much for your attention. I should have told you I have a slide problem. I always make too many slides. And so I used some of the do no harm slides here, which I teach for all professionals how not to do harm. But I also couldn't help but putting in even more. So hope it will be helpful for you and your followers or anyone who sees it to be safe when you're doing exercises and to make educated decision of the treatment method you might choose in the future.
Andrea, that was an exceptional presentation. Thank you very much. You went all the way from history, which I didn't know, but I do know that yellow book you're talking about. It's so complicated.
I could find it. It's probably here, actually. I could reach the latest version. This is the latest version. It's in German, though.
Okay.
And it has colorful pictures. But you know what I'm talking about. And
absolutely. Do you have time to go over a couple of questions?
Sure.
We're way over the length, and I appreciate that. Now, I'm glad you mentioned with the VBT, and you have about 4 or 5 young ladies who are post-VBT, and they were probably disappointed that they didn't have full correction, right? In terms of the posture.
Yes.
But that's the whole idea with bone modulation, and they'll grow. How important is it to continue asymmetric exercises in terms and maintaining proper posture when you're doing those exercises, I should say, after VBT?
So what I give them after VBT is actually more of a symmetrical exercises. They are achieving the symmetrical postures in the posture of 3D posture corrections when they do the correct standing, correct sitting, and we do the strengthening that way. We don't necessarily go into asymmetric poses. We might go into a left side lying if there are weakness in the core of the lumbar touched scoliosis. Let's say left lumbar, we might work on the right side of the quadratus lumborum iliopsoas just to stabilize the lumbar. But with the positioning, we achieve already the correction and already the VBT is done. So the cord inside is doing the correction as much as needed. What we work on, though, is the directional breathing. So the directional breathing is maybe done in an asymmetric position because it helps the ribs to open when it's not touched. So that could be looking like a one-sided exercise, but I would say that would be only the left side lying. All the other exercises would be in a symmetrical position.
So just to follow up to that, so if there's still some rotation or pelvic shifting, even after VBT, let's say there's a 50% correction, you still kind of focus on the symmetrical strengthening exercises on only a couple of the asymmetric ones.
Yes, because we have to make sure that all the exercises are in a perfectly corrected 3D posture. So if the pelvis is shifted, we won't give them anything until we teach them how to go in the middle. Now, if it is an exercise or a position which will help them to do it, like lying on the left side, then it looks like it's an asymmetric exercise because we're only going to do that on the left side. But otherwise, it is really still working the muscles in a balanced way. Okay.
Now, I'm glad you brought up in the slides the anterior vertebral overgrowth that causes the wedging at the front of the vertebra, which causes the loss of the curve and an increase of the hyperkyphosis, which drives the curve laterally into the coronal plane. When you have a patient, for instance, that gymnast that you highlighted in the slide, and they want to keep doing the gymnastics where there's just lots of hyperextension, what do you say to those patients?
So often I do have some high level of athletes and even ballet dancers. You can talk to, I ask them, go and explain to your coach, go and explain of the choreographer who's making a choreography, what you want to do and what you want to avoid. And maybe they come up, unless you go into the Olympics, there's no way you have to do it that way. So we have many times I've talked to coaches. Right now I have almost the whole team of the canoe both Olympic team, because they all have a little bit of asymmetry or scoliosis here and there. So we talk and we decide which side to sit, what to do. We talk about it, how to find a way, if you're in fact training for over 15 hours a week, to make a little bit more harmony in the balance of the movements, rather than expose the movement which comes the easiest to do. So they are always very attractive.
Extension. Yes.
As they go over to the left side, let's say a side bending, so the choreographers say, oh wow, let's do that. Or yeah, so it has been successful in some cases. Other cases, if the child is not so keen or the family is flexible, they don't go competitive, they just go for a few hours a week and create a variety of activities and sign up for a variety of activities. So it's not just the same repetition of let's say a choreography over and over and over again, but do a little bit of soccer, do a little bit of swimming, do a little bit of something else. And that way we don't limit really the physical activities, we just suggest that you can think. And some kids are very good at thinking of what they can or cannot I mean, not like we don't stop them to do it, but what is beneficial for them and what. And they tell the coaches, no, I'm not doing the split that way anymore. I have to do the other way, or I'm not going to hang on this way on the whatever bar. I'm going to do it with that way. So it is something which is a communication. It's not a restriction.
Okay. For patients who've already undergone VBT, how soon after surgery can they start going into those exercises? Do they have to get clearance first, and once they get clearance, it's fine?
So we ask for clearance. When the surgeon says, and some surgeons says next day you can do whatever you want, or some of them may say come back for the 6 weeks and then you do whatever you want. We have very little restrictions coming from surgeons. They really go for the individual's quality of life. But we also had Dr. Vitali on one of the webinars here on SSOL, and he said, we know that the cord is not going to be there forever.
100%.
So it is something which will get loose or snap, or we know. So it is, for our physiotherapy point of view, we do educate the patient maybe a little bit more on, look, this is where the cord is. This is when you stretch the cord. This is when you're not stretching the cord. But we don't limit them per se if the surgeon didn't limit them. But I think the education is very important.
Okay. And I just have one last question. Since a lot of most of the exercises with Schroth and C's, et cetera, are active traction, how do you feel about passive traction in terms of, just trying to lengthen out the spine without any active component? Is that a benefit or not so much?
So depends on what the goal is. Okay, passive traction has been around in the history for a very long time, and with severe curves, you have halo traction and passive traction. We use a lot of traction. We try to imagine it's active because the kids are holding their hands on a wall bar. Traction using the gravity is a good force, let's say. Passive traction without stabilizing afterwards could create some issues. So if, let's say, I'm just hooking up a lumbar curve into a traction machine, and let's say there are some stiff segments of L1, 2, 3, and L4, 5 is quite mobile, the traction is going to pull L4, 5 and not necessarily the apex or the curve. So it is a problem of knowing where this traction is happening. If it is happening in fact in the segments we actually want it, or that's the structural component of this curve which is stiff and tight, and no matter what you're pulling, it's really gonna pull the other segments. So it's a little bit tricky that way. That's my opinion only. There's no research or anything showing that, but it is just common sense, I think, because you're gonna have L4, 5 very mobile and functional and hypermobile most cases. And we know that 70% of the lordosis is happening in that level. And we know that we try not to fuse the patients all the way down to make sure they have all the mobility. So we know that's a very mobile segment. I'm sure there's research on that. But on the other hand, the curve and the apex is very unlikely that's there. It's usually lumbar apex is L2, L1, maybe L3. And those are not as easily accessible, let's say, with the traction. That you cannot really pick that level with the traction unless you are the surgeon and you know what you're doing there, because it is really isolation when you have to do those segments. So that's a little bit tricky, and this is why adults, we don't hang them and we don't let them do the same exercises as the teenagers, because they are definitely have more stiffnesses and tightnesses and stenosis and whatnot, calcium deposits. And by the time we hang them, we have no idea, are we mobilizing some segments which should not be mobilized more? Or in fact, are we helping their curve? So we don't hang them, for example, the same way as teenagers. In teenagers, we hope that they're flexible and they're managing, and maybe they're getting a little bit of, not necessarily traction, but a little bit of elongation.
Some gapping, if anything. Okay. All right. Thank you so much.
You're welcome.
I learned a lot myself. Very much appreciate your time, and we'll have to do this again sometime, but for adults scoliosis.
Wow, that's a long topic. There's a very good, I would say, try it out. I mean, if you go to SSOL, it's the same thing. We're just talking and presenting the same way.
Right.
It is very easy access, and we have a very good adult. We have very good post-surgical presentation there.
Okay.
We have surgeons. I think they're much better than what I could say. So.
Okay, great. All right, so we'll end it here. Thank you very much again.
You're welcome.